Wow.
All
So it's
right.
recording, so you'll say something, the other ships are going to hear it.
Yeah, so if you say something ridiculous, just know that you're going to be recorded. That all that always motivates people to participate in the classroom.
Right?
Okay. So we're going to do behavioral emergencies today. We're going to get 3 hours of special patients today. So we'll go ahead and start. We got a few things to talk about. Now, this class being about behavioral emergencies, you got to understand that we're talking about the full broad spectrum of behavior. So it might be secondary to trauma or medical or electrolyte or psychosis. It could be from illicit medications, drugs. So it's a full spectrum behavioral class today. So if there's something that you have an interest about, maybe it's a call you've made some time ago or whatever, and you want us to talk about it, discuss it, hey, just jump in there. Natalie and Michael, Kale can tell you that my classrooms are very laid back. I don't. I'm not here to bore you. That is the last thing that I want to do, is to bore my classrooms. I want my classrooms to be funny. I want them to be relaxed, and I want us to learn something. So if you got questions or comments, hey, just jump in there. All right. Here are the objectives. I'm not going to go over them with you. We'll just, of course, we'll touch on these points as we go through the class. Let's start off with this. Let's do a little case study here. Let's pretend that we're dispatched to a college residence hall to see a 20-year-old female complaining of fever and fluttering in her chest. You find her awake, but she appears very anxious. Okay. You can see that her airway is fine. She's breathing a little bit fast, but no obvious, breathing, no adventitious breath sounds, anything like that. And as far as circulation, everything's okay. She's a little fast and she's warm, pink, and dry. Okay. So let me just, I'm going to kill this for just a second and just let y'all think about that for just a second. And while you do that, I'm actually going to do something here. Give me just 1 nanosecond.
She's anxious about college.
Anxiety attack things.
Oh, she might have a UTI.
There's a lot of things. I mean, that's good that y'all are throwing some differentials out there.
UTI.
No.
What? Methamphetamines. Drugs. Or she took Adderall.
One too many.
One too many for studying for finals.
Get like two of them bad boys. 20 minutes. I've never taken this.
I'm just, yeah.
I've never taken one. I do, but I've heard very good things about it. I think I would like to be addicted.
Could you imagine calling that?
Yeah.
Calling 911.
Get senior day, pop and Adderall real quick. All right, we're good.
You're right. Okay.
Okay, so you tell your partner, say, hey, grab some vital signs, and you're going to put this lady on a little bit of oxygen because she's breathing a little bit fast. And this is what you find on the physical exam. Obviously, she's got some anxiety. She's easily startled. She's kind of jittery. She's just like a cat on a hot tin roof. Doesn't take much of an external stimulus to cause her to jump and to be startled. Like we said, her skin's warm, pink, and dry. She may be a little flushed around her cheeks and her neck, maybe a little bit flushed. And as you would also expect, her hands are a little shaky, a little trembly. Her head also, her head's got a little bit of a shake to it. Her lungs are okay, clear, equal breath sounds. And then by now your partner says, okay, got vitals. We got a pulse of 120. It's strong and regular, and got a blood pressure that's decent. She's breathing 20 times a minute. Tidal volume is good. They got a D stick, which is normal. And now we have her on the monitor, and she's showing a sinus tach with an occasional PAC. Okay. So there's just a little bit more information for us to, a little bit more crayons to paint us a more accurate picture about maybe what's happening here. Okay. Does anybody have any questions or anything you need to clarify so far about this? If you do, I'll do my best. Okay. Well, here's some more information. So this young lady says, this has happened before, but it's never lasted this long, and she's just almost tearing up and crying. She's very nervous. She's not been sick lately, other than some recurrent diarrhea and a little bit of weight loss. But what's up with that is that she says, I got some exams coming up, and I got some tuition payments coming up, and that's just a little bit of a problem for me. So I think maybe me having diarrhea, losing weight, maybe what's going on with, the bills and tests and exams and stuff like that. She's got no medical history. She takes no meds. She denies any use of any drugs, and she has no family history of pulmonary disease, diabetes, or heart disease. So it's a pretty benign scenario, other than you've got this young lady. How old was she? 20-year-old. Okay, so she's 20 years old. She's having a little bit of diarrhea, lost a little bit of weight, nervous about some exams and finances. What does anybody have anything? I heard you guys bouncing around some ideas when I was kind of getting some stuff done here, and I loved it. I like what you've got to say there. So does anybody have any additional differential diagnosis, or are we able to narrow it down even a little bit more? What are you guys and girls thinking?
Probably anxiety, no drug use.
Okay. Anxiety from maybe some college age drug activity. It's possible. I mean, it is what it is. Okay, very good. Anybody else with any thoughts?
No.
Okay. All right. Good deal. Fair enough. So what have we learned so far? Not much.
No.
Boy, that's a good teacher for you right there. What have we learned? Not much. The truth of the matter is we just, it's too vanilla. There's just not enough there for us to go, aha. Okay. So what we have learned, actually, yes, we have learned something. What is it? What have we learned? We've learned that this is not always easy, and we're not always going to have something that points directly to a very accurate field diagnosis. So behavioral emergencies can be very vague, very confusing, and we might not know what actually is going on with the patient until we hear from the hospital or something like that, So that's just the nature of the beast. All right, let's see what else we can do. Here's another one, a different patient. So now we've got this 44-year-old guy who passed out. You arrive to find him semi-reclined in bed. He's in his house. He's awake, very wide-eyed, and appears tired. Like his eyes are like just, owl. His eyes look like hoot owl eyes, and he's just got bags under his eyes. He just looks like he's exhausted. All right. Airway is fine. Breathing is fine. Circulation, rapid, weak, irregular radial pulses. So this is probably the most significant thing for so far is this one right here, is about circulation. Rapid, weak, irregular radial pulse. So with just what we have so far, what are some ideas that we might consider? What might be going on?
Dehydrated.
Okay, I heard dehydration. Somebody was saying something before that I couldn't quite hear.
Castle said AFib.
Oh yeah, absolutely. Absolutely. Could be an onset of atrial fibrillation. It could be dehydration. Anybody else? Natalie? What? I can't hear her, Kel.
She was saying dehydration, and Mitchell
Oh,
was
okay.
saying cocaine.
Okay. All right. Good. All right. Very good. Let's see what else we can rustle up here. So we get some vital signs and a history. This is the history. This is the history of the present illness. For the past month, okay, so there's a pretty significant length of time. For the past month, he's felt weak and dizzy. Now, that's a long time for a guy to be weak and dizzy, okay? He has not felt like eating. He's been losing weight. Also experienced nausea, vomiting, diarrhea on a few days this month. All right, so again, my wheels are turning. Okay, I'm thinking, all right, that's definitely gastrointestinal symptoms there. Let's see what else we can find out. His past medical history. His past medical history has been fairly healthy all of his life. 3 months ago, he became ill with bacterial meningitis, for which he was successfully treated. Now, what do we know about bacterial meningitis? This one thing we know. Bacterial meningitis will kill you in a matter of hours if it's not treated appropriately. It is very, very deadly. Okay. This guy had it. Thank God. Apparently, he got the right treatment, and so he was able to recover from that. What is bacterial meningitis? What part of the body does that affect?
Nervous system.
The nervous system is correct. Okay. Remember that the central nervous system, the brain and spinal cord, the central nervous system has 3 layers of meninges that are responsible for protecting our central nervous system. And can anyone tell me what those 3 meninges are, just for a little bit of fun and trivia?
No, that's his brain. I don't think, is it the it's not the majors, is it?
It's no, I'll tell you what, this is a way that you can remember a little bit of a way how you can remember this is the meninges are responsible for padding the brain and spinal cord. So they're responsible for padding.
You've never had this.
And what is the D?
We're over.
There you go. Excellent. Now, I know that this is not a central nervous system class, but this is just good refreshers. So bacterial meningitis is this bacteria gets in the meninges and it just gravely insults the brain and spinal cord. Maybe when you were doing your paramedic rotations, when you were in paramedic school, maybe in the emergency room, you got to watch a doc do a spinal tap on a kid, and they bow the spine forward and they get a spinal needle and they tap into the meninges there and they drain out a little bit of CSF fluid, cerebral spinal fluid, and they're checking for clarity on that. So maybe you've been able to experience that or not. But anyway, let's get back to this guy. Let's see what else. Here are the vital signs. Pulse is a little fast and irregular. Blood pressure is doable, but I wouldn't be comfortable with it getting much lower than that. Breathing is fine. Skin, this is not good. Skin is cold and clammy. Atrial fibrillation. Of course, this would go coincide with this, but his dextrose is fine.
That's what's calling sepsis.
Just okay. I've got a sepsis.
Sepsis.
I've got an onset of atrial fibrillation. Natalie is saying dehydration. Now, I know that Natalie may have changed her mind, and if she did, that's fine. I'm just going to put what she originally said on here. Dehydration. Is there anything else we need to put on here?
I think it's one of those.
Okay.
No, I think the AFib was just.
The AFib symptom of the sepsis.
The AFib is a compensatory mechanism for the sepsis.
Who said that?
Castle.
Oh, Castle, hush. I'm teasing. I'm kidding with you, brother. No, that's a good thought. Okay. Very good. Now, here is the last one. Here's the third one. You notice I'm not telling you what the answers are, haven't you? That's because I will tell you later on in the class. Okay. Here's the last one. The last call of your shift, manufacturing plant for a possible drug overdose. Your patient is 24-year-old female. Supervisor states the woman seems very jittery and out of it. Now, this is probably talking about a mental state. I don't know yet. You find the patient to be a very thin female who is acting unusual. Airway is okay. Breathing is fine. Circulation, strong, rapid, regular radial pulse, clammy skin. This is not good. And this might be problematic. Disability, she is confused and answers questions slowly. Well, that is not good either. Okay, let me hear it. Thoughts?
Check her blood sugar.
All right, dextrose, and what was the other one?
Pupils.
All right. Pupils, we need to find out what the pupils are. I'll give that to you here in just a minute. I love that assessment. Okay, what else?
Organophosphates.
Organophosphates. Okay, anything else? Good. I love it because y'all have a broad range of differentials here. Your partner gets some vital signs. You got a pulse of 110. That's not that bad. Okay, pulse of 110, strong and regular. Blood pressure is okay. Ventilation, let me just check. I think that's okay. I think that's okay. That's okay. The skin is not. The skin's not okay. Pupils, dilated. They're equal and they're reactive to light. EKG, sinus tach without ectopy. And the history, there's no significant medical history, no recent illness, and she takes no medications.
Any recent trauma?
No. No recent trauma.
You had any alcohol in this?
Alcohol? Is that what you...
He's asking if there's alcohol intake.
No. No alcohol intake.
Any drug use?
No, sir.
What's in the manufacturing plant?
Okay. So I love it that you remembered that she's very thin. Okay. Very thin female. That is going to be a bigger piece of the puzzle than what you might think.
Is
Okay.
she anemic?
That's a good thought. She could be anemic. She could be anorexic. She could have bulimia. She could have, there's a reason why she's so thin. All right. Let's keep working through this. Okay. Any other thoughts?
So today, well, side note, today's Natalie's birthday, and she's got a huge bouquet of flowers and chocolate.
Ah.
Hold your bouquet up.
Yeah, look how red.
That's all I know.
Well, Natalie, are you married?
No.
Do you have a fiance?
Not yet.
You
Yeah, but
obviously have a
I don't know.
significant other.
Uncle Sam. He has to read the card.
She's got to read the card. She's about as red.
Pass.
She's about as red as this cup right here. That's from her parents.
Oh, it's from her parents. Natalie,
Yeah.
how old are you?
6.
Geriatric age.
Griffin's 5.
Did she say she's 26?
She turned 26.
26. Natalie, would you like for me to help you? Did you say help what?
Help me? Is that what you said?
Yeah, would you like for me to help you?
Sure. Sure.
You know, Miss Natalie, I teach about 500 paramedics every month. And I run across a lot of good-looking single guys. Kale, you're going to have to help me out. I can't hear what she's saying.
She's laughing. She's turning redder and redder.
Now the boyfriend's got to step up though.
Oh, yeah?
Oh, Natalie, I'm just playing with you, okay? Happy birthday. Okay. A coworker now tells you that the patient is going through a difficult divorce and has not been eating well lately. Your partner now tells you that the blood glucose is 40.
Yeah.
Oh, that's
Yeah.
yeah.
This is an aha moment. All right, very good. Okay, so we got the ice broke, we got the juices flowing in our minds. And so now let's jump in here and let's talk about some differentials that are going to play a part in some of these behavioral emergencies. Do not forget the easy stuff. Hypoxia. Okay, remember when you were in EMT school? Remember hypoxia, and I'm preaching to the people that have red patches right now. Okay, so hypoxia, strokes, TIAs, any type of a cerebral event, diabetes, endocrine issues, psychosis, emotional issues, street drugs, and some other stuff we'll talk about. Let's start with hypoxia. Remember that EMTs save paramedics. Now, I have worked with EMT Basics as a partner. I have worked with paramedics, obviously, as partners. I have worked with nurses as a partner when I was a flight medic. And I had rather have an EMT Basic as my partner than anybody. I love having an EMT as a partner. You know why? Because they save my hiney. A lot of times I'm thinking way out there, deep pathophysiology, medications, blah, blah, blah. And I've got an EMT that's bringing me back down to earth. And bringing me back to some very foundational stuff, and it has helped me more times than I can remember. So, with that being said, ladies and gentlemen, let's not forget about hypoxia. Hypoxia can cause behavioral issues, and I will just use my sweet mom as an example. At the very beginning of the onset of my mother having lung cancer, she started having some personality changes and some anxiety issues. And come to find out, the reason for those changes in my own mother was because of her lung cancer, and she was in a state of hypoxia. And she was not complaining of shortness of breath. She was not having any labored breathing. She was not having any chest discomfort, no color changes. She only had behavioral changes. And that's my own mother. I still wear my mother's wedding ring. I loved my mother. Okay. So let's not forget the easy stuff. With every altered mental status, we must prove that hypoxia was investigated and prove its existence or its absence with every behavioral emergency. You gotta start with the basics first. Number two, strokes, TIAs, any type of a cerebral event. Again, this is very basic to the pre-hospital medicine that we practice in the field, and that is we got to remember the easy stuff. Every behavioral presentation must be assessed for the possibility of a cerebral event. It must be either ruled in or ruled out. So on every emotional behavioral difference, paramedics, red patches, listen to me. I'm not your QA guy, okay? But if I was your quality assurance person, and if I saw that your patient had any type of a presentation of a behavioral difference or behavioral issue, I'm going to see if in ESO you did a stroke assessment, because it's basic. And last but not least, our third scenario brought this out. And again, we can't forget the easy stuff. So yes, on every altered patient behavioral, we got to do a D-stick. Okay? All right. Are we good? Are y'all mad at me?
We're good.
Okay. Now let's talk about some illegal stuff, some illicit substances. This is now getting very realistic with the young generation out there. Y'all are very close to Denton, Texas, which has, I think, 3 different universities there in Denton, Texas. So just a lot of college, university students there. And you know, some go to study and some go to do other things. So let's talk about this. We're going to talk about alcohol, and someone asked about that a while ago on the third scenario is, did she have any history with alcohol substance? So very good. Absolutely good thinking. So alcohol, THC, meth, heroin, synthetic opioids, these are big, big problems today. And I know I'm very aware that I'm preaching to the choir. Okay. You guys know this. You're in the field every day, and you guys and girls are in the age category to where you know what's going on socially out there. And this is a problem. And let's review some of this stuff. We're going to start with tetrahydrocannabinol, THC. Okay. Some of you I wish I could have had a close up of Natalie to see if she's turning red right now. I
She's
would.
turned back to normal color.
Oh, me. All right. So, what are we talking about with THC? We're talking about weed. We're talking about marijuana. Okay. The THC is a stuff that is the chemical in the cannabis that makes people want more of it. Now, we're gonna start with Delta 8. Please help me if I'm a little bit behind. Remember that I live in a jungle, and a lot of time I'm out of touch with what is new and on the scene. Okay. So is there a Delta 7 out there?
There's a Delta 9 now.
There's a
Okay.
Delta 8,
Okay.
Delta 10, Delta 11.
Oh, okay. Now I'm hearing something that I didn't know. I know about Delta 8, 9, and 10, but I don't know anything about 11. There is a Delta 11 out there?
Yes.
Okay, so thank you for that. I'm gonna go on Google and I'm gonna search that. I'm gonna study it out. Okay, it's my responsibility to know what material to bring to you. But we're going to start with Delta 8. Delta 8. Let's read this. Now, I'm not a slide reader. I'm not a death by PowerPoint type of guy. I hate those kinds of instructors. Okay. But let's read this. Delta 8 is a psychoactive substance derived from cannabis. Duh. It can cause side effects like anxiety and confusion. Now, there's a reason why I put this in red, because it directly correlates to the topic of the class, and that is behavior. Okay. So it could be that you have somebody out there that's partying with some Delta 8 out there and it turns out to be a behavioral emergency, and they're anxious and they're confused. Okay. So Delta 8 should be in one of your differentials. It can also alter the heart rate. It's not regulated. Now, listen to me. It's not regulated by the FDA and are synthesized from hemp-derived CBD, leading to significant health issues. And I'm going to underline or circle this significant health risk, because it is not regulated. And anytime that we have a substance, drug, pharmaceutical substance out there that's not being regulated by FDA, the sky is the limit. We don't know what people are putting in this stuff, which makes it very risky. Okay, it's a gamble. Many Delta 8 products are manufactured without safety regulations, making their contents, such as the amount of Delta 8 or other harmful chemicals, unreliable. Okay. Any questions about Delta 8, or is there any other information that needs to be talked about in regard to Delta 8?
Oh, I think so.
Okay. All righty. What's your favorite flavor, Kel? Is it grape or cherry?
Cherry. Red
Yeah.
cake back on the habitat days.
Yeah, my favorite's the cherry too. I tried the grape. I'm not a fan of the grape. I like the cherry. All right, here we go. Delta 9. Delta 9, guys and girls, this is the main psychoactive compound. It's the main thing in cannabis. Delta 9 is not a trade product that you find in a vape store. Now, you can find it marketed as Delta 9, but Delta 9 is actually the chemical compound in weed. It's the actual stuff that makes you feel like you feel, right? So it causes the high associated with marijuana, and can be extracted from marijuana or hemp. Delta-9 is known for its psychoactive effects, and that's why people like Delta-9. With high doses, Delta-9 can cause paranoia, panic attacks, hallucinations, and confusion. Delta-9 can knock you on your fanny. Now, let's talk about Delta-10. Delta-10 is naturally occurring, but a rare cannabinoid. It also is found in hemp and the cannabis, often created from CBD. It produces psychoactive effects. Now, again, that's in red lettering. Similar to Delta-9, THC, but is considered milder. With many users reporting uplifting and energizing experiences, Delta-10 is available in various forms. Okay. So Delta-9 is the big stuff. Delta-8, I'm not really familiar with the Delta-8 that much, but Delta-10 is sort of a watered down version, if you will, of the Delta-9. Now, you know what? Let me go back. I don't think we're finished with marijuana. Let me just visit for just a second.
You've made it too strong now.
These Delta, these Delta products.
THC in some of those.
We'd say regular weed that you get, and then run it through butane, and so the THC level will be 19%, and then run butane through it, and your THC level is 99.
So that's too much.
But like if you're smart about it, so we'll make it eventually becomes dabs.
I was about to say, it's when people dab.
And so, but you'll take 2 grams of regular flower or bud, and you'll end up burning through it in, say, a day or an hour. Versus the dabs, because it's such high concentration of THC now, it lasts you longer. So you
Yeah,
save
but
more money.
but they take too much of it. They
Yeah,
don't
but you
don't
do-
want they
do
don't
that
want make
side
it
effect
last long
for-
enough.
And over, and then you come back down to the normal.
No.
And you do it again.
Chemistry class.
Ketamine.
That's the one.
K-holes.
Morphine.
No, I thought it was with some deals of marijuana, straight deal.
Yeah,
That's-
that's if you get it laced.
It's laced.
I was like,
What else do we have on THC?
Well, what I was going to say, Kel, is that the health community, they really honestly are making some very impressive strides with using THC, CBD, those types of things with treating these diseases out there. And I believe that now, rather than having the door closed, we've cracked it open a little bit for consideration. And
Yeah.
we're finding out that there's actually some very legitimate uses out there for people with a lot of, for example, Parkinson's disease.
Right.
There's a lot of good stuff coming around the corner with this, I believe. So.
Isn't the VA looking at a bunch of?
Yeah, so they were looking at using it for PTSD and then the ketamine therapy. Well, and then in Oregon, they were talking about using shrooms,
Right.
legalized that.
The MDMA.
And then also they were talking about changing it from the class 1 scheduled drug to potential class 3, but it really wouldn't do anything for its users. It just on the tax break and being able to actually regulate the taxes on the federal level. So they're talking about potentially making it to more of a class 4 where you need a prescription, but like how everywhere like up north has medical necessity for it.
That's a policy we're gonna have to look at one day.
Yeah. Yeah.
Chicago and Seattle and places
Yeah.
where how they can do certain tests to see.
Yeah.
They kind of line it as the same as you can't drink before you come on ship.
Right.
Even like the Canadian military, like they were first, you can smoke, but on your off days.
Oh.
I mean, I'd argue alcohol is a lot more dangerous than marijuana if you get it from a dispensary where it's all drinking.
Oh. Not.
Says the one that's 20 and can't drink.
And shit.
I've heard it's really good to
Castle's a young pup. He's 20 years old.
Well, it's good to have young people in our profession.
It is. We like him. We'll keep him. Nah.
All right, so let's talk about some other stuff, y'all. Good discussion. I love it when we just, kick the chairs back and let's talk about some stuff. That's what makes CE classes really good CE classes. Rather than some guy up there like a stupid robot just clicking screen, clicking, going to PowerPoint. Well, let's talk about this stuff, okay? Okay, let's talk for just a minute about methamphetamine. Meth is a huge problem. It is a huge problem. Methamphetamine was first made in 1893. 1893. Some of you guys, have y'all ever heard of something called Methergin?
I'm sorry, Metrogen?
Methergin.
No.
So.
Okay, we're going to have a little bit of fun. Get your phone and Google Methergin.
It's like a caffeine thing. So it'll set it.
This is stuff they did not put in your history books.
Is it medication treats excessive bleeding after childbirth?
No.
Mhm.
Where's my phone? I've got my wires crossed here. Let me see if I can find it.
You say Medrogen?
No, METH.
METH. Meth.
Ogen?
ER, Methergin.
That's what I thought. Yeah. Because it's an ergot alkaloid used for smooth muscles.
Hang on, I'm going to tell you
Heard
who
'em?
it is. I'm sorry. Here we go. Let me just write it on the screen here. I said it wrong. It's not Methergin, it's Pervitin.
Perfect.
Oh,
Oh, it's the brand name.
It's used by the Nazis.
Yeah.
Oh, dude, let's keep them awake.
Yeah.
It's like
Hitler.
controlled experiment.
Yeah. Yeah. The SS were, they were.
The Russian sleep experiment? No, the
No,
Blitz, like the Nazis. There's
Yeah.
a book called Blitzberg
Yeah.
that talks all about the meth use,
The-
coke use.
The SS, they were all on meth.
Yeah, Hitler was too.
Yeah, Hitler was using, I want to say in his peak, it was like 80 grams a day.
His doctor was keeping him.
That's
Yeah.
true.
Yeah. That's what the SS were. Crazy.
Yeah.
Meth heads cannot run.
Anybody want to take a wild guess? What country invented methamphetamines?
Sweden,
Nope.
Finland, Germany.
Nope.
Germany,
Nope.
Austria.
United States.
It's the other enemy of World War II?
Japan.
Kamikaze soldiers.
Japs made it up? Yeah, because kamikaze pilots.
Yeah, they used it.
Yeah. So methamphetamine has been around for a long time. Okay.
Yeah, they did it.
It is very, very powerful, and it is a very strong addictive substance to the central nervous system. It is a very, very powerful stimulant. And we were talking about the SS, the Nazis, World War II, the Japanese, the kamikazes, bonsai soldiers, all those types of people. They would just take that crap and they would just lose their mind, being overly stimulated. So meth releases high levels of dopamine in the brain. Now, if you'll remember in paramedic school, dopamine is brain candy. It's brain candy. The brain loves dopamine. So anytime anything is taken in the human body that releases these neurotransmitters, dopamine in the brain loves it and wants more of it. And meth, they say, causes an extreme euphoric rush. And it is extremely addictive, and it causes not only physical harm to the body, but it also causes irreparable psychological harm to the body as well. Physical changes, these include increased heart rate, blood pressure, body temperature, and a decrease in appetite. Okay, so remember maybe back to some of our scenarios that we were talking about at the very beginning of the class. Okay, and then at the bottom it says psychological effects, paranoia, anxiety, as well as aggression. Now, at the very end of the class today, we're going to talk about something called excited delirium. And excited delirium, a lot of times, is triggered by the use of meth. But we'll get to that a little bit later on. Okay. But methamphetamine, you got to consider all of these parameters when you're dealing with behavioral type emergencies. Now, let's talk about nitazene. Have y'all heard of nitazene?
No.
Nitazene is new. All right, this is something that's new on the scene, and it is becoming quite a problem. Look at this.
Oof.
How does that compare to Dilaudid?
Dilaudid is like baby food. I don't remember the states. I apologize for that. I don't remember the states, but there was some of this stuff coming in and hitting the streets, and these heroin dealers are mixing it in with their heroin products to make it more appealing to the heroin addicts. And they've got like a 99% death rate with heroin laced with nitazene. They say that it will immediately paralyze the central nervous system and immediately, while the needle is in their arm, stop breathing.
No returning customers.
Exactly. If they're gonna use that crap, they're gonna have to cut it a lot.
I think they're just trying to say, kill their enemies.
Oh.
Customers say, hey, just don't bring wood, just come back to me.
Yeah, so this is nothing new. Heroin has been around forever. Big thing now is ketamine. Special K, ketamine is a big deal now. your fentanyls. Fentanyl has been a problem for quite some time now. So these synthetic opioids, guys, can cause, as we all know, some pretty big problems. Now, let's move to a different category. Let's talk about disorders of the endocrine system. Now, diabetes is obviously in this problem with the endocrine system, but diabetes is a whole different class, CE class by itself. So I'm not going to talk about diabetes today. So I will talk about a couple of other different types of things that are problems with the endocrine system. And let's just jump in here with thyroid issues. Okay. Thyroid issues. What time is it? Hey, we've been going for an hour. Do y'all need to take a break?
Let's take a quick break.
Yeah, let's do that. Okay, I've got 2:30. So how long a break you guys want?
Let's just do 10.
Attaboy.
Okay.
At 5
How's
to
that?
10. That'll work. Yeah, we'll get water, bathroom, and we'll be right back.
Okay. All right. I think I'm going to go to the bathroom too. Sorry, Natalie. That might have been a little too private. Sorry about that.
It's all good.
Kind of talking to you, out there from your parents. I'm like, you can share those topics.
Ferrero Rocher.
Pretty sweet to your parents.
Oh, yeah.
Do they live in California or they just?
One's
Is
in
this the
California.
different, what's this code we get out here? 7150?
But they're
Awesome.
911.
So Cali, once you.
Kel, are y'all there?
There you are.
Hey.
Hey, Paul. It's just me and Darren in here. They all kind of went on the wayside, but they'll come
Uh,
back.
oh, okay. I didn't know if maybe you guys had got a call or.
Oh, no.
Oh,
They're all
okay.
going to the restroom and whatnot. Yeah. Oh, yeah. Oh, boy. I just can't figure out why the people would, put all that bad substance in their body like that. Yeah. That's what my theory are.
Did you unmute it?
Okay.
Okay.
Yeah.
Oh, we're gonna move that camera so they see which.
I didn't know that. You get something.
We're back, Paul.
Okay.
We got held up talking with Chief a little bit.
Okay. No, that's fine. Okay. So we're going to talk about the thyroid function a little bit. It's part of the endocrine system, of course. And so let's talk about thyroid issues. We as paramedics, we don't learn a lot about thyroid when we're in paramedic school. So I don't expect anybody to be like, endocrinologist for sure, but let's review this stuff. The thyroid gland, we know what the thyroid gland is because we intubate people and we learn about the thyroid cartilage and where it is when we start learning about advanced airway stuff. So you can see the picture of the pink items on this diagram here, and that is representing the thyroid, the thyroid gland. You can see that it is on the left as well as the right side of the trachea, and it's just below the thyroid cartilage. Okay, the thyroid is a very important part of the human body. And some people have problems with thyroid. Some have hypothyroidism, and some people can end up with hyperthyroidism. But let's talk about thyroid levels. People who have thyroid issues, especially the hypothyroid people, they end up not having a lot of energy. Their metabolism is slow. They gain a lot of weight. And so, especially women these days in weight loss clinics, one of the first things that the doctors are going to do is they're going to draw thyroid levels to find out if the thyroid is functioning properly because it can cause a weight problem. So this is how it works. It all starts in the brain. Now, in the brain, there is a little bitty thing about the size of a pinto bean called the pituitary gland. The pituitary gland is responsible for a lot of different things. But one of the things that the pituitary gland is responsible for is secreting something called TSH. And I'm going to circle it up here. Well, I thought I was. TSH. TSH, that stands for thyroid stimulating hormone. Thyroid stimulating hormone is produced in the pituitary gland. Okay, what then? The thyroid stimulating hormone is circulated And its purpose is to stimulate the thyroid gland to start producing T3 and T4. So think of it like this. The pituitary gland up in the head, it releases TSH, thyroid stimulating hormone, and what that does is that does CPR. It does CPR on the thyroid gland in the neck to produce the thyroid 3 and the thyroid 4 because it's not doing it by itself. And so when the pituitary gland recognizes, oh, there's not enough T3 and there's not enough T4, then the pituitary goes, well, let me see if I can help them out. And I'm going to produce TSH, and it's going to do CPR to try to revive the thyroid gland in the neck to start doing its job again. That's the very reason why we do CPR on the heart, on the chest, is we're trying to get the heart to start doing its job. And the pituitary gland is trying to get the thyroid gland to do its job. Except it doesn't do chest compressions, it releases TSH. Okay? Now, that's all I'm going to say about that. It gets a little complicated, and that's something that I don't want to do. Let's talk about abnormal functions. People who have hypothyroid problems produce too little of T3 and T4. Well, that's going to cause problems. Okay. What kind of problems? Well, it's going to cause a problem with people losing energy and sluggish, and they're sleepy. They don't have a drive. They don't want to do anything. They're gaining weight and just a lot of different things. So when T3 and T4 levels are low, that means hypothyroidism. T3 and T4 levels are low. When T3 and T4 levels are low, TSH levels are going to go up. Why?
The pituitary gland's trying to compensate for the lack of a thyroid gland.
Exactly. Very good. And that's as deep into this as we're going to go. Okay. Now, this will all make sense here in just a second, so just be patient with me. Now, let's talk about the other extreme, which is hyperthyroidism. Okay. Two things that can come from hyperthyroidism is thyrotoxicosis, and the other one is a thyroid storm. These people are in harm's way because a thyroid storm can kill people. This is when we have too much thyroid hormone. And it's almost always due to the patient accidentally overdosing on their thyroid medication. For example, Synthroid. Synthroid is a very common medication that we run into in the field a lot when we are using our tough books and we're in ESO and we're in there listing the patient's medications. And a lot of times you'll run across Synthroid because people have thyroid issues. When a person accidentally takes too much Synthroid or other type of thyroid medications, the thyroid levels are going to build up and up and up and increase and increase. And a lot of times that won't be caught until the person is in a very dangerous situation. So hyperthyroidism can be something really, really bad. Okay, so let's go back to hypothyroidism. This is the bottom line. The bottom line is this. It causes a decrease. Now we're talking about hypo. It causes a decrease in the basal metabolic rate. Somebody take a stab at that. What are we talking about? Okay.
This
Think
means
about.
they'll just have low metabolism, tired, not able to function normally throughout the day.
Uh-huh. Exactly. Okay. I'm going to challenge you to think back to capnography classes that I teach, capnography classes. Remember, let me draw a cell here. Let me draw a human body cell. And here is the nucleus. And there's little things in here. They look like beans in here. And those are mitochondria. Y'all remember me talking about the mitochondria? Okay. There are two things that have to go inside of the human cell in order for that human cell to live. What are those two things?
Two things that have to go in the cell for the cell to live.
Glucose and oxygen.
Absolutely right. Okay. There's got to be a glucose that goes inside there, and there's got to be oxygen. There has to have oxygen going in there as well. And as long as we have those two things, that cell right here is going to live. These little things in here, these little bean-shaped things in here, these mitochondria, are the places where metabolism takes place. In other words, it metabolizes the sugar and the oxygen to create life. And in paramedic classes, you'll remember that that's called ATP, adenosine triphosphate, which is life. Now, that is metabolism. That's very, very basic metabolism science class from 5th grade, okay? So with that being the case, look at this circle up here. Thyroid hormone deficiency causes a decrease in the basal metabolic rate. So what that means is that this person is going to slow down in almost every single way. And the next slide is going to prove that to you. Causes of hypothyroidism. Well, it's genetic. People may not be taking their levothyroxine or their Synthroid. It is an older person issue sometimes. But hypothyroidism, here is a slide of the presentations of hypothyroidism. And as we look at this, I'm going to challenge you to note about the metabolic rate slowing down everything about the patient, including behavioral, since this is the class today, behavioral issues. It slows down or insults cognitive function. Slows it down. These people are always going to be complaining of being cold. Because what does metabolism, an increased metabolism causes heat. Okay? Remember that from the, again, capnography classes. Low blood pressure, low heart rate, muscles are weak, decreased respirations, slowed metabolism. They're gaining weight. GI motility is slowed down. Circulation in extremities is slowing down. Dopamine production is slowed down. Everything about the patient is too slow. That's because the cells are not metabolizing appropriately because there's just not enough thyroid. Facial edema, loss of hair, dry, coarse skin. All of these are signs of hypothyroidism. And these up here are signs of what they call myxedema. The hair looks like hair on a mannequin. Y'all remember old mannequins in clothing department stores that had hair that looked like broom thistles? Okay, dry, coarse, thick hair. The outside edges of the eyebrows get very thin. They have bags under their eyes, and they get dark. Puffy, dull face with dry skin. That is myxedema. Here is a picture of an example of dry, coarse skin from hypothyroidism. Now, there's a lot to this. However, the main takeaway is up here, because we're talking about behavioral emergencies. If we have a 70-year-old patient that is on levothyroxine, and they live in an impoverished setting, and you can tell that they don't have a lot of money, and you get there because of a behavioral issue, and you get someone who has a decreased level of consciousness. They don't know who they are. They don't know where they are. They keep closing their eyes. They start drifting off into a stupor. And you notice that one of their medications that they take is levothyroxine. What are your thoughts?
Can't afford a medication.
Exactly. They can't afford their medication, so they haven't been taking it. So this is just an example of how different endocrine systems can be the culprit. It's not always dextrose. Sometimes it's thyroid. Any questions about this? Okay. Good class. I like the way you guys are participating. Now let's talk about the other side called hyper. Okay, hyperthyroidism. Well, guess what? The people are just going to be the other. They're going to be on the other side of the spectrum. Okay. Excessive levels of thyroid can cause a hypermetabolic state. So this person is sped up. Okay. They could be over medicating. Okay. Also, other things that can cause the thyroid levels to go crazy are Gorder's and Graves' disease, and another one that I'll tell you about here in just a second. Hyperthyroidism, Graves' disease. You'll hear people talk about, well, I've got a history of Graves' disease. And one of the telltale things about Graves' disease are these big bulgy eyes that look like they're protruding out of their head. Okay. Bags under their eyes. Okay. That's Graves' disease. These people are going to be sped up. Everything's too fast. They're nervous, irritable, trembling, paranoid. They have warm flush skin. They're hot because of the metabolism. They're tachycardic. They can have high output CHF, high blood pressure, breathing too fast. GI motility is too fast. They're having diarrhea. They're losing weight, again, because of the metabolic rate. And they may have a goiter. Okay, a goiter in the neck. This is an example of normal thyroid glands, and this is an example of enlarged thyroid glands, which can cause goiters. So if you have a patient that is nervous, irritable, shaken, they're hot, they're flushed, they're tachycardic, their blood pressure is high, they're breathing fast, they've had diarrhea, they've been losing weight. Scenario number 2. From the very beginning of the class. Okay, now a thyroid storm, I've already told you, can be fatal. My wife in Honduras about 3 or 4 years ago had a thyroid storm. And it was probably one of the scariest things that I've ever encountered in my life, to be in a jungle in the middle of nowhere, knowing that my wife is in the throes of death. And and she had a thyroid storm, because in Honduras you don't have the ability to get your thyroid levels checked, because there's just not any hospitals there, not where we are. And Kay takes thyroid medications, and she was supposed to have gotten her thyroid levels checked before we left Texas, but they didn't have an opening. And this is what Kay said: "Oh, I'll be fine." Yeah. And so over the following months, her thyroid levels just kept getting higher and higher and higher. And she actually legitimately went into a state of psychosis. She didn't know who I was. She didn't know where she was. She was having delusions. She was having hallucinations. She had a sustained heart rate of 140. It was bad. So anyway, long story short, I was able to get her to a hospital and get her taken care of. But a thyroid storm, these people are crazy. My wife was guano. Do y'all know what guano is?
Guano,
Yeah.
bat poop. That crazy.
Exactly. That's what my wife was. She was guano. Oh my God, this is being recorded. I forgot.
That's all right.
Don't ever show Kay this video. Okay, so here's thyrotoxicosis: severe tachycardia, heart failure, dysrhythmia, shock, hyperthermia, abdominal pain. And they can be very similar to someone with excited delirium syndrome. Now, let me tell you another one. Hyponatremia. This is low. What in the world? This is low sodium. Low sodium. Hyponatremia. There's some things that can cause people over time to become too low on sodium levels. But let's just read this. It says in hyponatremia, one or more factors ranging from an underlying medical condition to drinking too much water causes the sodium in your body to become diluted. When this happens, your body's water levels rise and your cells begin to swell, including in your central nervous system. I had a lady on a call one time. It was about 9 o'clock at night, and this lady was probably in her early 70s, and she was loony. I mean, she was just off her rocker, and her children were there, which they were, in their early 50s, and her children would say, "This is not our mother." And this woman was a leader in the community. I mean, she was an upstanding lady in the community, and she was cuckoo for Cocoa Puffs. And her sugar levels were fine. We did everything we could in the world to find out what's going on with this lady. Ended up getting to the emergency room, and I told Dr. Work, ER doctor buddy of mine, I said, "Hey, when you find out what's going on with her, give me a call because I want to know what's going on with her." And he gave me a call and he said, "Hey, come up here to the ER." So I went to the ER and he showed me her labs. He says, "Look at her sodium level." And her sodium level was a critical low. I mean, it was low. And I looked at him and I said, "You got to be kidding me." I said, "Are you telling me that this is what caused her to do that?" He said, "Oh, yeah." I said, "Really?" And so I found out that night that people who have really low sodium levels, they can go guano. And so anyway, I'm just passing that along to you. Also, let's not forget that there are also EKG changes that can happen with hyponatremia, mostly seen in V1234 here. Now, I don't intend on going into this because this is not a 12-lead class, but you can see that the ST segments are really elevated, which can tend to make us think about it being a STEMI, right? So, but anyway, that's for a different day, a different class. And in red letters again, one of the things with hyponatremia is confusion as well as psychosis. Now let's talk about PCOS, polycystic ovarian syndrome. There's a lot of young ladies, excuse me, out there that have cystic ovaries. There's a good chance that you may know somebody with polycystic ovarian syndrome. And these young ladies have really, they just have battles. Every month, their period is just crazy. They have extra long menstrual periods. They come and go, they're not regular, and they're very painful, very painful. And polycystic ovarian syndrome can cause a lot of problems, but look down here at the bottom is psychosis. Now, I know of a patient, she is 20, this is actually in Honduras. I had a patient, she was 25 years old, and she had a history of PCOS, and she legitimately went psychotic for about 2 months. And come to find out, her problem was polycystic ovarian syndrome. Polycystic ovarian syndrome can cause really high testosterone levels in the females. and can cause facial hair, weight gain, big bulky shoulders, a lot of things. So if you have a young lady, blonde haired, 26 years old, got flowers, and she all of a sudden has a psychotic episode, and her mom and dad are saying, this is not her, this is not her, this, she doesn't have a history of anything like this. But as you are doing your due diligence on scene, the mother tells you, no, the only thing that she's got wrong with her is she's got a problem with cystic ovaries. Aha. She has a history of polycystic ovaries. Okay. Now, I'm not saying that this is a nailed down diagnosis, but it absolutely is worthy of consideration. Psychiatric, emotional illnesses. We're going to talk for just a little bit about these things. What is delirium? What is a hallucination? Dementia? What is catatonic behavior and manic behavior? So these are legitimate people that are MR patients, mental health, mental retardation patients. These people are psych patients legitimately. Okay, so it's going to be worth our while to go over some of these things. First of all, let's look at these definitions. This is the definition of delusions, hallucinations, and illusions. And it's worthy of our time to look at these to notice the differences between these words, because what I have found is that paramedics a lot of times use these words interchangeably, and they sometimes are passing on information that's not exactly correct. Okay. So a delusion is a fixed false belief that cannot be corrected by logic. You can explain to them, you can prove them, you can show it to their face that they're wrong, and it's not going to do any good. They will not be convinced. Okay? Are not consistent with culture and education of the patient. These people are delusional. They are believing something that is contrary to their history, and you cannot prove them wrong. Okay, they're delusional. Hallucinations. These are false sensory perceptions that are experienced without real external stimuli. Okay, they're seeing things that are not there. Okay, I'm sitting here in the class, and all of a sudden, over by the door, I see a purple elephant with orange stripes, and I'm telling you, no, I see it. It's right there. I swear to God. I don't know why you can't see it, but it's right there. Okay. They're hallucinating. They're seeing things that are not actually there, which includes sounds. They can hear sounds, and each different pitch of the note produces a different color. Okay. Welcome to LSD back in the 60s, 70s. And then illusions. An illusion is a misperception of a real external stimulus. Okay, so they actually do experience a stimulus of some kind, but their brain misconstrues it to be something else. Most likely to occur when general level of sensory stimulation consciousness is reduced. Okay, these people are confused, and you touch them and they say, don't scream at me. I'm not screaming at you. I just touched you. Well, stop screaming at me. Okay. So anyway, delirium. Delirium is a temporary state of mental confusion and disorientation that can cause significant changes in the way people think, behave, and perceive things. Okay. So a psych patient in a state of delirium, they may have a mood or personality change. They may have a fit of anger. They may use bad language whenever they're a Sunday school teacher. Just a lot of things. Okay. They are having a state of delirium.
I have a question, Paul.
Yes, sir.
With these patients that are in a delirium or excited delirium state, even if they answer our ANO questions, perfectly fine and whatnot, what is the best way to talk to them in a way that we may be able to convince them to go to the hospital when they really need to go?
Well, that is $1,000 question. I can't give you an answer from my personal experience, but I can give you an answer from a lot of studying and a lot of video. Actually, I've got one that I'm going to show you. I have seen, actually, Dr. Stuart Kaufman. Nobody knows Dr. Kaufman, do you?
No.
Okay, you know your medical director, Zach Bazell?
Yes.
Okay, Dr. Kaufman is Dr. Bazell's boss.
Okay.
Okay, so Stuart Kaufman, Dr. Kaufman and I are good friends, and Dr. Kaufman was one of the founding charter authors of the white paper report on excited delirium. So he is the go-to guy about excited delirium, and he's the one that taught me about excited delirium. So I developed a pretty strong personal interest in excited delirium. So I have watched a lot of footage, a lot of video of excited delirium patients. And the thing about these patients is that sometimes they will miraculously hear you and they will listen to you and they will actually tell you, I hear you. I understand you. I understand you need me to stand still and you need me to stop thrashing around. I'm trying the best I can. And they have the awareness of these things. They just don't have the ability to do anything about it. So you know how ketamine is a dissociative medication, right? Ketamine, it separates the mind from the body. That's why it's such a good pain medication. Okay, so excited delirium, I'm not saying it's like ketamine, but think about it like that. Excited delirium, there is a separation of knowing and hearing what you're supposed to do, but your body just can't comply. There's an excellent video on YouTube, and it's about an excited delirium guy. I'll tell you his name. It's on YouTube. Donald Lewis. Donald Lewis, and you can type in excited delirium.
Is he teaching about it or is he experiencing it?
And in the video, what you'll see, if you watch it, Donald Lewis is trying to obey. He's trying to comply with the officers. He just can't do it. And the police officers don't know how to handle that, and they end up killing him. It actually shows him dying on the video, so you may not want to watch it if that bothers you. But I don't know if I'm answering your question or not. I guess my simple bottom line is I don't know. Sometimes they'll listen to you and they're able to stand still or be still, and sometimes they're just not going to do it.
Have you found ways, like if you kind of present with a calmer voice, and like what? I mean, obviously don't go psycho around, but you know, like if they're saying, "Oh yeah, we see somebody there," don't be like, "Okay, yeah, he's right there."
You can use their phone for
Bring
your
it out.
like people they love. Yeah, and that's something that
What's your thoughts, Paul? I mean, how do you help your patients when they're just going crazy, or do you get them out of it and kind of sedate them?
was stroking septic. So that's reasons. Well, yeah, and that. Yeah, lots of that. Sepsis.
You there, Paul?
Yeah, I can hear some of it, Kel, but some of it I can't hear.
Yeah, Mitchell was just asking, is it, a calmer voice, or Trimmer was saying, let family members talk to them, before you.
Yes,
Yeah.
absolutely. The video I'm going to ask y'all to watch here in a little bit. The police department that is on scene with this excited delirium patient, it's evident that those cops have been trained about how to deal with excited delirium patients. And because of their training and because of their calm demeanor, and they didn't press him, they just kind of stood back, they handled it like $1,000,000. They did a perfect job. Whereas this guy, Donald Lewis, they didn't know how to handle him. And they killed him because they didn't know what they were doing. So a calm voice, don't pressure. Do not pressure them. Don't give strong orders to them. Don't try to be a commando. You got to handle these people with kid gloves. So, yeah, I hope you guys never have one of these calls, but you will. If you're in this business long enough, you will. You'll end up having one. Okay, I'm going to wind this up because I don't even know what time it is. Oh yeah, I've got to hurry. I got to get through with this. So let's just skip through some of this stuff: manic behavior, catatonic behavior, suicidal ideations. We get a lot of those types of calls. The average in the USA, the statistics right now is 13 suicidal deaths per 100,000 people. In the United States, firefighters are at 18 per 100,000 people.
Yeah.
So firefighters face a lot of stuff. I mean, you just do. It's the nature of the beast. That's why you got to talk. You got to have somebody. You got to have an ear. You got to have a shoulder, and you got to be willing to open up, because what you keep inside of you can kill you. And I've said this to you guys before. Natalie and Michael may not know it, but I'm a preacher. I'm a minister. And if Oak Point or any of you guys or girls ever need a debriefing, just let me know. If I'm in Texas, you can count on me. I'll come up there and we'll do it. But if somebody comes up to you and they're trying to open up to you, the worst thing you can do is look at them and go, really? You're going to have to put your big boy britches on. You know, you're going to have to toughen up. That is the worst thing that you can say to somebody. Okay? Not everybody is somebody else. I mean, some people it bothers, and some people it doesn't. So if somebody comes up to you and says, hey, you know, and they start trying to open up about it, you should say, hey, hang on just a minute. I'm going to fill up my tea glass and let's go in here and talk about it. That's what you should do. Talk to one another about it. People that have suicidal ideations, some of these people actually legitimately do not want to hurt themselves, and you know that, and I know that. But what they're doing is they are screaming for someone to help them. If I tell you, because Kale, I know that if I told Kale, I need you to help me out, man, I'm in a bad way. I know that Kale would help me. I don't have any doubt about that at all. Okay. If I tell him with my mouth, Kale, I need you to help me. That's one mode of communication. That's one mode of communication. Another mode of communication is taking a razor blade and slicing your wrist. Now, that person didn't ask for help, but that person is asking for help, if you can follow me. Okay? So let's help each other. Let's not be those hard-butted people. Like, oh my God, you know, can you believe that, you know, blah, blah, blah. They need me to teach them how to do it. They need me to teach them how to load a 45 and how to stick it in their mouth right. You know, don't be that person. Don't be that person. Okay? There's people out there in this world that are hurting. And there's a lot of people out there in this world that need help. I'm sorry. I got preachy. I didn't mean to do that.
Oh, you're good, Paul.
Okay. Bipolar disorder. Bipolar is just an up and down thing. These people, they feel really good. They're elated. They're like happy. Let's go party. Let's go drink some beer. Let's do some tequila shots. Let's go play some music, you know, and they're all up. And then all of a sudden they crash like a stinking bag of bricks. And they're depressed. They want to go somewhere dark, shut the room up. You know, those people are bipolar. Autism, a lot of children, look at this. According to the Centers for Disease Control, autism affects an estimated 1 in 54 kids. There's a lot of autistic kids out there these days. My stepson, Connor, Connor just had a birthday. He's 10, and Connor is autistic, and he's on the lower level on the spectrum of autism. He can say, you know, a few words, put a few words together and stuff like that, but he is OCD. He's got to line up all of his toys in order by color. You know, it's Rain Man. So you got to know how to handle these autistic individuals, and it's not just children. It's adults too. Some adults have autism as well. You got to know how to handle these people. Okay, there's some videos that I was hoping to have time to show y'all. This is a video about a child that has a meltdown. And so if you have your phone, if you want to take a picture of the screen so you can watch it later on, you can do that. It's about this person having an autistic meltdown. Attention deficit hyperactive disorder. You probably have some firefighters that work for y'all with this. I'm serious. There's a lot of firefighters and paramedics that are in this profession that have ADHD, and it's like, dude, can you just calm down? You know, just go have a gummy. Let me go get you a Delta 9. Uh, Schizophrenia. These people live in a false reality. They see things legitimately. They see things and they talk to these things. People. They live in a false reality. It's like living in Oak Point, and at the same time, you're living in the Lord of the Rings. At the same time, it's a very sad diagnosis, schizophrenia. There's another video if you'd like to watch it. Maybe you do, maybe you don't. Panic attacks. We have a lot of panic attacks in our profession, and a lot of them are in the Latin culture. Latin cultures, predominantly females, they have a lot of panic attacks. Let me just tell you this. Panic attacks are real, period. They're real. Now, does that mean they're going to die? No. Does that mean their life is in jeopardy? No. But to them, it's a reality. Okay. So, for example, the only person I can see in the room is Natalie, so I'm just going to pick on Natalie. It's her birthday. I got to pick on Natalie. Okay. So I can see Natalie sitting over there in the chair. And if I said something to Natalie and she came up to me an hour later and she says, "Hey, Paul, you hurt my feelings during CE class." And I said, "Oh, okay. I didn't know. What did I say?" And she tells me what I said. And she said, "That hurt my feelings." And I said, "Oh, come on. No, it didn't." "Yeah, it did." "There's no way that could have hurt your feelings. That was nothing. I was just kidding. There's nothing to that. You need to toughen up, girlfriend." Okay. Now, to me, it was nothing. But it's not about me. It's about Natalie. To Natalie, it's a real deal. I hurt her feelings. And just because my feelings weren't hurt doesn't mean that it wasn't so. No, it hurt her feelings. And so, therefore, it is a real event to her. So, people who have panic attacks, it's a real deal to them. So, how about this? How about 1M? How about compassion? We're in this business to be public servants or we're not. If you can't show compassion on people, go to work at Home Depot. Go somewhere else. Now we're finally at excited delirium. Excited delirium. This is how they're going to present. A very aggressive person. Paranoia. These people are strong, very strong, superhuman strength, exceptional agitation, nudity. And let me just talk to you about nudity for a second. The reason why they're nude or mostly nude is because they are hot, sweaty. Why are they hot and sweaty? because their metabolism on the cellular level is going crazy. And the reason why they take off their clothes is because they're hot. It's not because they're some kind of freak. Okay. Hyperactive, it may come in as a property damage call, a suspicious person call. And then when the person has what they call the terminal event, they sudden collapse, this is when they die. And these people will die very easily. Their heart rate is crazy fast. Their heart, their whole body, their whole metabolism is spinning out of control, and just a little bit of stimulus can kill them. The biggest problem may come after the excited delirium person is controlled. After struggling against a restraint, there may come a period of sudden tranquility. At this point, this professor says the officers realize the subject has stopped breathing, and invariably resuscitation efforts fail. These people are not resuscitated. If you decide to watch the Donald Lewis video, you will see that.
Is it due to like hypoglycemia due to their metabolism just going wild, or what is the cause of failed resuscitation?
Excellent question. There's two. What they're finding is that there's normally two factors at play with an excited delirium person who doesn't make it. They have a past medical history of some sort of mental or psychosis. And then that person takes a strong stimulant such as meth. And those two together, the way the chemistry in the brain, the neurotransmitters in the brain are just out of control. And you know that the brain is, it's the motherboard of the body. And the blood pressure, the vessels, the heart rate, the metabolism of the cells, everything is, the RPMs are supposed to be 700. This is just relative example. RPMs are supposed to be 700, but with excited delirium, they're like 70,000. And it doesn't take much more to throw a rod and blow the motor up. And that's exactly what happens with excited delirium. So when you watch the video of Donald Lewis struggling and fighting, and they're fighting with him, it was just too much. And it was the straw that broke the camel's back. And I don't know exactly why they're not resuscitated, but their heart has got to be destroyed from all of the sympathetic stimulation from the brain, that it's just not going to happen. The electrical pathways are fried. Okay. I bet you. Let's see. It's not going to let me watch it, I don't think. Maybe. No, it's not going to do it. Okay, do this. Get back to where I was. Come on. Let's see. What does this say? Well, heck, I'm not going to be able to show you. I tell you what, y'all, just breathe for just a second.
Hey, I think there's still coffee on the. Has he seen your story?
Oh, I don't know. Where they put that candy machine in here? Candy machine?
Nah,
Nah.
Candy.
Or whatever.
vending machine.
Yeah,
There's a
it's,
vending machine in there.
yeah.
Revenue store?
He's in the jungle. He was out.
What are you watching?
Fort Worth Fire.
Fort Worth Fire.
Where they collapsed, the garage collapsed.
Is that on YouTube?
Yeah, it came up on my Facebook. This is for.
Well, I don't know why it's not working, guys.
Technology, Paul.
Yeah, it aggravates me to death whenever I find something that I'd like to show y'all and then it doesn't work. Okay, well, it's not going to work. But the video, the video is an actual call made in Dallas. The Dallas Police Department caught the call. They called Dallas Fire Department out there, and they handled the thing totally wrong. And the lady, they have a cop in the back of the ambulance attending with the paramedic, and they're back there making fun of her while she's handcuffed to the cot, and she stops breathing, and they don't even realize it until she's already arrested, and they never get her back. So, but anyway, dadgummit, I wished I could have played that for y'all. Okay, but that's all we've got time for today. Let me give you guys our QR code. Oh, point 2025.
So we keep track and see.
Yeah, it'll sends you a certificate for the hours.
Will we email, will we do it?
It'll be emailed to you.
Okay, y'all should be able to see the QR code now.
Yep. What? Yes.
All right, I'm gonna kill the recording while we do this.